So Dr. NEENA ma'am, she will be doing her next talk on real world scenario of progressive myopia, case-based discussion.
So I want this to be an interactive session. So I have put across some cases which have come to my OPD, and I would like to have the opinion of the expert panel and even the audience. So this is a 15-year-old girl with uneven birth history using glasses from 5 years of age. She was on regular follow-up till COVID. Then she was lost for follow-up. Then a year back she came back, and then she came up with she came after COVID with progressive myopia. No family history of myopia. So this is her, current glasses. With current glasses, she's reading 612 N6, mild myopia with astigmatism predominating. But her current cyclorefraction had shown there was a jump of 0.75 diopters in the right eye and 0.75 diopters in the left eye. So axial length was also recorded. What will you do for this patient? Now parents are concerned. She said she had changed her glasses about 6 months back, and now there is a big jump. What will you do? She's 15 years old. So what would you do, Dr. Sumita, in this scenario?
The age is the factor that you need to consider. Parental myopia. So I think no parents with myopia. And she's a 15-year-old, means she's crossed the peak years of progression. And though the recent change is of concern, what we see in our scenario is these 8th, 9th and 10th board people typically show a progression during that time. Yeah. So though literature says that the peak years of progression are until 13, 14, in my experience, what we have found, I'm sure you've also found that we still continue to see progression until about 17 or even 18 years in some children. So we cannot take this lightly. So definitely I would start at least a low dose atropine in such a child. Also give the option of spectacle lenses, myopia control spectacle lenses. So depending on the affordability, either of them to be started.
So that's exactly what we did. We started her on low dose 0.01 atropine at bedtime. And we advised 6 monthly follow-up. So at the end of 6 months, she was stable on low dose atropine. Axial length was evaluated, and she was advised 6 monthly follow-up again. At the end of 1 year, she was stable on low-dose atropine. So these are the pointers which she already mentioned. So we can maintain her on low-dose atropine as she's nearing adulthood and she may stabilize spontaneously. Coming to the second case, that of an 11-year-old female child, again, little higher myopia, again, no family history. But there was a jump of about 0.5 sphere in the right eye and 0.25 sphere in the left eye with some changes in the cylinder. So they said they had changed the glasses 6 months back and they were concerned about frequent glass change. What do we do now? Again, here we started low-dose atropine and single vision glasses were given. At the end of 6 months, again, there was a jump. The myopia was progressive. This time there was a significant increase in spherical equivalent and axial length was noted. So there was a rapid progression. So what would you do in this case, Ramya or Dr. Sumita?
Either we can increase the dosage to twice the atropine daily, or better here there is an axial length change, so better to put on 0.05% atropine or start on a progressive glasses.
Yeah. So, so these are the pointers here. So initially mild progression, but there was a rapid progression. But remember, she's not having family history of myopia, but this is a younger child in growing phase. So these are the options we could give. We could make the low dose atropine twice daily, or we could switch over to 0.05, a higher concentration, or we could directly give peripheral defocus glasses. So they opted for twice daily atropine, and that's what we did. And what did happen? After 6 months, she was stable. So she was advised to continue the low-dose atropine twice daily. But at the end of 1 year, yeah, again, the refraction was stable. So an axial length, there was a minimal change. But since refraction was stable, we maintained her on single vision glasses with twice daily atropine. Coming to the third case, a 12-year-old boy, normal developmental milestones, but mother is a myope. So current PG showed a jump of about 1.25 diopters in myopia and 1.5 diopters in the left eye. So a very rapid progression in the 6 months. So axial length was recorded, and this child gave a history of having used low-dose atropine earlier, but had discontinued it because of non-compliance. So parents were concerned about the rapid progression. What do we do now? Dr. Sumita, would you like to answer?
The age again, Dr. Neena?
Age was he's about
12 years.
12 years, yeah.
Okay. So a 12-year-old boy showing significant progression. Again, there was some progression in the cylinders also noted. Just make sure there is no history of eye rubbing. Rule out any corneal ectasia because we're seeing a quick progression. That is one thing. And considering this parental history of myopia and he's just 12 years, he is going to show significant progression. So at this scenario, I would like to discuss about compliance with atropine with the parents. If they think the child is not going to be compliant or they have a very busy schedule where they cannot ensure compliance, then the best thing to be to go forward with would be defocus glasses or ortho-K lenses is something that I would definitely like to counsel the parents about.
Yeah, so that's exactly what we did. And the parents didn't want atropine because child was not compliant. So we opted for peripheral defocus glasses, that is HALT or CARE was explained, and they chose HALT SLR Stellus lens. And what we found after child is on regular follow-up. At the end of 22 months, child is stable on HALT lenses. So he's advised to continue the same. So these were the pointers she has already explained. Now, this is an 8-year-old boy using glasses from 4 years of age. Both parents are myopic here. And you can see 8-year-old boy with significantly high myopia already, minus 6.5 diopters with a minus 1.5 diopter cylinder, and significantly increased axial length also. Parents are concerned about further progression of myopia. They said they changed glasses 6 months back, but again a jump. What do we do now? So, what do we do now? So this is a very significant myopia. And so we started the child on low dose atropine 0.01 with single vision glasses. After 1 year, again, big jump, 0.5 increase was noted. So what do we do now? We made the low dose atropine twice daily. Now again jump after 1 year. It has increased by again 0.5. Despite being on twice daily, what do we do now? So Dr. Letika, would you like to put in some points? What could we do now? Already atropine has been made twice daily. Remember, at this time, we didn't have 0.05 atropine at that time. We only had 0.01. So that's why we made it twice daily.
Yeah. So I was thinking about 0.05% atropine actually as the next step, but probably a combination therapy using multiple modalities may be the way to go.
Yeah. So this is, if you don't, since we didn't have 0.05, we went ahead with gave the option of special glasses, myopia defocus glasses with atropine. And that's what we did. The glasses were changed to Stellest and low dose atropine was continued. But again, at the end of 1 year, there was increase in axial length and spherical equivalent. What next? Now we have tried everything in our armamentarium. Only one thing is left, about which Dr. Sumita discussed, orthokeratology contact lenses. We gave the option to the parents, but they didn't want to use contact lenses because of problems with hygiene and health, and we decided to continue the same. But this is one place where you can definitely recommend orthokeratology contact lenses. Thank you very much. I hope you got some take-home pointers. And I thank all the co-instructors and the audience